morning. Good morning. Thank you for coming. My name is Jan Van Riper. I'm the Interim Executive Director for the Institute of Health and Humanities here in Missoula, and we help put together and invite speakers for Ethics Month, which is usually in April here for Friday medical conferences. So I have the privilege of introducing our speaker today, Dr. Stewart Justman. And before I do that, I wanted to let you know that there are two handouts on that table back there. There is no PowerPoint today, so you want to make sure that you grab a handout so you can follow along a couple of times. Actually, one handout is a list of references, and I understand that the references are in the order that they're referenced in the talk, just for your information. So again, if you haven't grabbed those, this is a good time to do it. Okay, so I'm pretty happy to be able to introduce Dr. Justman, and very thrilled that he agreed to give this talk here today. He is a professor at the University of Montana and directs the Liberal Studies program there. He has served the University of Montana for many years, receiving at one point their Distinguished Scholar Award. He has a lengthy CV with all kinds of books and articles that he's published. He writes at the intersection of science, medicine, and humanities. He's won many honors and awards, and for example, here's one of his books that he published, or was published a few years ago. It's called The Seeds of Mortality, The Public and Private Worlds of Cancer. He got the Penn Award for the art of the essay for that one. Another one is Fool's Paradise. It explores the self-help literature for which he received the Popular Culture Association Award for Best Book of the Year. He's had a couple of his books reviewed in the New England Journal of Medicine, and I could go on and on about his articles and books and his many awards, but I know that you would rather hear from him, so I won't do that. Do want to mention one other thing about his background. He's been an invited speaker at the Clinical Pharmacology Division of the FDA. So he writes a lot of stuff, and he's well received by the academic, the medical, and the popular audiences. So, and before he takes the stage, I just ask you that he'll give his talk, and if you would hold your questions towards the end of it, we would appreciate that. Have I forgotten anything here? Okay, it's my pleasure to introduce Dr. Justman. Thank you.
Thank you. Okay. So I have a tale of unintended consequences for you, which will arrive at what I hope is a controversial conclusion. Story begins in the 1950s. So how does a drug get to be on the market in the 1950s? The first celebrity drug, the first psychoactive drug embraced by the American population at large, has the folksy name of Milltown. It's meprobamate, a minor tranquilizer, kind of a forerunner of the benzos. How does a drug like that get to be on the market? Well, at the time, there was no FDA requirement that a drug show efficacy before being marketed, although a drug could be pulled from the market for being unsafe. That's another matter. We'll get to that in a minute. So the drug did not go through the kind of clinical trial probation that we expect a drug to go through today as a result of that, which we're going to get to in a second. But let's say once this drug is out there and already in wide use, and the drug conquered the marketplace almost as soon as it was introduced. Let's say independent-minded researcher decides to test its efficacy after the fact. Well, that was done with meprobamate and other drugs. And in the case of this sensationally popular drug, 80% of clinical studies, it was shown not to be superior to placebo. In 1959, Senator Kefauver, who was sort of a minor household name, senator from Tennessee when I was a kid, began holding hearings. He was concerned with drug pricing, sound familiar? And he was concerned with the lack of an efficacy requirement. Began in December 1959. His hearings bogged down and went nowhere, although they occupied heaven knows how many pages of the congressional record. They went nowhere until something happened in 1962, which people of my generation indelibly remember, and that is the thalidomide disaster, which broke in the summer of 1962. And when it did, the Kefauver-Harris is the name of a congressman, the Kefauver-Harris amendments to the FDA legislation, that's what they're called, amendments, which were destined for defeat. Well, that situation was changed so dramatically that they were passed unanimously by both houses of Congress. And as they were undergoing floor debate, Senator Javits from New York inserted a provision for informed consent, which is the first appearance of informed consent in the law of the land. It was inserted at the last moment. You'll have a reference for that on your reference sheet. It was inserted at the last moment, which suggests to me that it was not particularly well thought out. Certainly its implications were not. And even if they had been thought out, I don't think they could really have been completely foreseen. So this is Ethics Month, and informed consent is it's pretty much the first principle of medical ethics. Maybe I'm oversimplifying, but it basically is. How could it have any untoward, unforeseeable, and maybe not altogether fortunate consequences? Well, wait and see. It can happen. So the Kefauver-Harris amendments, which really launched the FDA as we know it today, a completely different entity than it was before 1962, has these two components. First of all, this is from the actual language of the legislation. Drugs had to be subjected to adequate and well-controlled investigations in order to be approved by the FDA. And in those investigations, informed consent was to be operative. Well, what could this possibly have to do with that? That's the theme of my talk. It has a lot to do with that. The results of adequate and well-controlled investigations are going to be different depending on whether informed consent is present or not. And we'll see. Well, I know that many regard informed consent as a kind of incomprehensible ritual. I have signed informed consent papers myself that are ridiculously lengthy and complex. I remember signing one where death was one of many possible side effects, and it was buried in the middle of the document, you know. So informed consent can be a kind of absurd, a ritual of absurdity. And it is known that many volunteers enter clinical trials without understanding that they are clinical trials. In other words, that they may not receive treatment. So they go through they are consented, they go through the informed consent process without even comprehending the basic point that they're actually entering a clinical trial. All that having been said, the fact is that informed consent can make a major difference. It can get into people's heads. It can change outcomes. It can change the experience of people in clinical trials. And here is one example, and there's a reference for you on the handout. It's one of my favorite clinical trials. It's from a study in 1987 that was conducted in 3 centers, and not that unusual, so, 3 centers, but there's a Murphy's Law, this kind of opportunity for Murphy's Law to take effect, right? So some sophisticated exercise being conducted in 3 places. Well, what happens if one of them kind of departs from the script? And that's what did happen in this case. Inadvertently, a different consent form was used at one of these study centers. The study involved 2 or 3 treatments for unstable angina with a total of 555 subjects. And it turned out that the center which did not list gastrointestinal side effects on the consent form, subjects at that center reported those side effects at 1/6 the rate of the other 2 centers. And for those of you who are statistically minded, the p-value here is less than 1 in 10,000. In other words, there is less than a 1 in 10,000 chance that this finding was chance. So it was clearly an outcome of this accidental disparity in consent forms. And I like this trial. To me, it's it's one of the most elegant bits of detective work, really, that I've encountered, because the managers of the trial had to figure out what on earth could possibly have produced such a pronounced disparity. That's just one example, kind of a proof of principle. Informed consent can change outcomes. It can break blinds, for example. Now, in the 1950s, before the necessity of adequate controlled investigations was written into law, people ahead of the curve in medicine, reformers, wanted to introduce some sort of clinical trial system. And the pillars of the clinical trial were randomization, placebo control, double blinding, and statistical validation. Double blinding, that is, a study is worthless unless both the investigators and the subjects are blinded. So let's just accept that for purposes of discussion or whatever. One thing that consent forms can do is break blinds. They can and do frequently break blinds. It's well known that double blinding is, which I say it's more common in theory than in actual practice in clinical trials. In a 1982 trial, which is referenced for you, in which 79% of those receiving the test drug correctly identified which group they were in, and I'm quoting now, the patients reported that the detailed consent forms alerted them not only to the possibility that they might receive a placebo, that's important, but also to the specific side effects that they might encounter if they received the drug. With this information, it was relatively easy for them to detect their medication assignment. So they entered a clinical trial. It's a 50-50 trial, and let's use that as the template for a clinical trial. They don't all fit that template, but I think that is the most common one, 50-50. So you enter your trial. Are you getting a drug? Are you getting a placebo? Well, if the consent form alerts you to certain telltale side effects of the test drug, and lo and behold, you experience those side effects, there you have it. Well, the story gets more interesting than that, because, of course, members of placebo groups start reporting the side effects that are reported in the consent forms. They report the side effects of the drugs reported in consent forms at fairly remarkable rates. All of this is governed by the consent form. According to a study published in the journal Pain in 2003, I'll quote, in clinical trials, the informed consent form normally informs patients that they will receive either an active analgesic agent or placebo, 50-50. Hence, patients know that there's only a 50% chance of getting a pain-relieving drug, and accordingly, they're less likely to expect and report high levels of pain relief. There you go. Basically, that says that the informed consent form gets into people's heads. And I think we can accept that sort of as just a matter of possibility. That can happen. Now let's get a little bit more specific. In a while, I'm going to get to this graphic, and for now, I want to just give you a little information about the paper in which this graphic appeared. It was a meta-analysis of 182 clinical trials of antidepressants. A meta-analysis, for those who might not know, is not a clinical trial, but it is an analysis of clinical trials. And maybe the more the better. In this case, 182 is an awful lot. And so you're crunching a lot of information there. A meta-analysis of 182 clinical trials of antidepressants has shown that when the likelihood of receiving placebo reaches 50%, the placebo effect drops, with important implications for the outcome of the clinical trial. The authors of this paper, whose names you have on the graphic, conclude, quote, that you can, they conclude that you can depress the placebo effect, quote, by explicitly and clearly stating the probability of receiving placebo in the informed consent procedure. So if you tell people that they have a 50-50 shot of getting the drug, or only a 50-50 shot of getting the drug, that does things to their response. And what it does, first of all, is reduce the placebo effect. That's important, as we'll see. I mean, because after all, if you're running a drug against placebo, right, and in order for a drug to be effective, it has to be superior to placebo. Well, what if you can mute the placebo effect? I'm simplifying a bit for time reasons, but that's the basic principle. Okay, if you're measuring drug against placebo and you're lowering the bar by lowering the placebo effect, which the 50-50 message does do, what happens? Changes outcomes. Well, the effect of that 50-50 language is illustrated for me very dramatically, not very dramatically, in a kind of appropriately dramatic way, by a study by my favorite placebo researcher, Fabrizio Benedetti, in which 3 groups of post-operative patients, strictly comparable, I think, were all given placebo treatment. Now, I think they were on an IV line, and they're all receiving placebo, but 3 different messages. Well, one gets no message. The second group is told you may or may not be receiving a powerful painkiller. What kind of a message is that? It's a weird message. And the third group says you are receiving a powerful painkiller. And guess what? The outcomes track the messages directly. And this kind of result is the opposite of an outlying result. It's very replicable. So group 3, the group that got the strong message, you are receiving a powerful painkiller, requested 16% less buprenorphine, a painkiller, than group 2. So I should say what the experimenters measured was everyone in the experiment could ask for any amount of painkiller. And so the endpoint, what was being measured, was the amount of painkiller requested. So group 1 that got no message, gave you a baseline figure. Group 2, which got the weird message, you may or may not be receiving a painkiller, requested a certain amount of buprenorphine. And group 3, which got the strong message, requested and received 16% less painkiller than group 2. This is a robust finding. So informed consent and the 50-50 message that goes with it lowers the placebo response, and in that sense kind of lowers the bar against which drugs are tested when they go through clinical trials. And on that point I'm oversimplifying a bit, but I think it holds. And please remember that ironically enough, informed consent was not part of the original randomized clinical trial RCT package that reformers, forward-looking thinkers, medical pioneers in the 1950s, is not what they were thinking of. So those 4 pillars of the clinical trial are, right, randomization, placebo control, double blinding, and statistical validation. Any one of those isn't in place, they said there's no validity to the results. But notice what isn't there. None of these people were arguing for informed consent. Informed consent is a kind of late arrival to the clinical trial system as a result of the thalidomide disaster, which is a kind of external factor. So a drug has to be superior to placebo in order to pass the efficacy test. This is called efficacy. So the drug has to be is to prove itself superior to placebo in a stage 3 clinical trial. Well, how do we calibrate the placebo effect? I mean, how do you measure it? That's a good question because the placebo effect is highly situational. It depends so much on the circumstances in which it's measured. And so take a look at this, at this point, at this graphic that I handed out. It's just not exactly self-interpreting, but what you have here are responses to the drug response and the placebo response in clinical trials of antidepressants. I keep mentioning antidepressants because, of course, it's very well known that antidepressant clinical trials are bedeviled by the placebo response. All psychoactive drugs show a very high placebo response rate. And in some cases, in fact, it's well known within and without the FDA that 50% of trials of antidepressants fail, as they do not show superiority to placebo. So what's interesting about this meprobamate example that I began with is, to me, so here's a drug that tests 80% of the tests to which it was subjected after being on the market. It's not superior to placebo. I should have mentioned that those tests, of course, did not use informed consent. This is before the days of informed consent. Informed consent is kind of a speculative thought exercise. Well, what would have happened if this drug, if the placebo response had been depressed in the clinical trials of this drug? How would the drug have done then? And no one really knows, but I think it would be foolish to assume that it would have fared exactly the same. Probably not. What this graphic shows, if you take a look, I think there were two telling columns, the first and the last. The last is the important one. What happens when people get the 50-50 message? And if you look, you'll see the placebo effect drops. Suddenly you see a drop down to 31, right? So it goes from 38, 38, 39, down to 31. And there's also, okay, maybe I'll leave that. What if we're testing a drug that is not, let's go back to meprobamate, and we have an idea that something is either a drug or a placebo. But what we have here is it's an ambiguous drug. And there are drugs, and I'm going to get to them by name in a couple of minutes, out there on the market, which are only slightly better than placebo. 10%, 5%, 2%. In order to be superior to placebo, how superior do you have to be? I mean, and then what does it mean to prescribe a drug that is maybe 5% better than placebo? So this doesn't look like much. Dropping the placebo effect doesn't look like much. But if you're dealing with a drug that is only a little bit better than placebo, that might be the difference between success and failure in a clinical trial. So that's the take-home message I'm trying to get across. That the consent procedure itself could be, if we're dealing with if we're talking about a marginal drug, could be the difference between success and failure. So with this, one way to interpret this graphic is that the 50-50 message opens up about a 5-point difference between drug and placebo if you look at the first and the last columns. There are some wrinkles here that I can't get into now, but there's a 5% greater difference between drug and placebo in this column than in that column. Well, that's a lot, 5%, because in other meta-analyses of clinical trials of antidepressants, there are many trials in the FDA's vaults of antidepressants in which they are less than 5% superior to placebo. Less than 5%. So the difference provided by the 50-50 message is more than enough to cover that case. Okay, so let's talk a little bit about ambiguous drugs that are out there on the market. You know, drugs that are, you know, well, I mean, are they drug? Are they placebo? You've perhaps heard of or saw on 60 Minutes, this is a few years ago, Irving Kirsch, who kind of blew the whistle on antidepressants after getting his hands on a lot of unpublished trial data in the keeping of the FDA as a result of a Freedom of Information Act request, or a Freedom of Information Act, whatever, petition. The book that he's a clinical psychologist, and his book, The Emperor's New Drugs, I find a very strong argument. I think it's well argued. He focuses on SSRIs, selective serotonin reuptake inhibitors, drugs like Prozac and Paxil, right? And it's well known and not controversial that in half of the trials of the drugs in this family, half of them fail. That is, fail to yield a finding in favor of the drug. So, and according to Irving Kirsch's calculations, based on FDA documents of unpublished trials, SSRIs like Prozac are about 82% placebo, but that's his conservative calculation. I think in his heart of hearts he believes it's a good deal more than that. So conservatively 82%. Okay, so now we have a drug that's like maybe 18% better than placebo. Second example, drug that's in the news, just a couple days ago, last time I heard of it, Addy, the female sexual desire drug that apparently isn't going anywhere in the market, right? Its generic name or whatever is flubanserin. Interestingly, flubanserin began its life as an antidepressant but failed to show efficacy. There you go. You kind of ran into the wall. And so its manufacturer, Sprout Pharmaceuticals, tried it for something else, and so it showed some efficacy as a female sexual desire enhancer, and the manufacturer, Sprout Pharmaceuticals, cites margins of responder superiority of 9.4% to 14.6% over placebo across endpoints. So it's about 10 to 15% better than placebo, according to the manufacturer. So SSRIs, maybe 18%, now we're down to 10, 15%. Now let's try Sarafen, which is a FDA-approved treatment for premenstrual dysphoric disorder, PMDD. Sarafen is actually fluoxetine. It is Prozac. It's Prozac by another name. It's just rebranded. So we're back to SSRIs. So in the dossier, in the FDA dossier for Sarafen, 3 trials. One, it included 3 trials. One in which subjects on 20 milligrams of this drug showed 8% more improvement than those on placebo. 8%. Secondly, a trial in which 2% more patients showed marked improvement on 20 milligrams than on placebo. Thirdly, a trial in which 20 milligrams of fluoxetine was not superior to placebo at all. So you're just getting right onto the margin there. Here's another example. How do you pronounce it? Who invents these names for drugs? But Tegazarod is Zelnorm. By the end of a 12-week trial of this drug that's sold as Zelnorm, it's for constipation associated with irritable bowel syndrome, IBS. By the end of a 12-week trial, the drug outstripped placebo on a global improvement scale by 6%. 6%. Now, that means that according to standard calculations, 17 patients would need to be treated with this drug in order for it to be effective as something other than a placebo in one patient. 17 would have to be treated in order for it to be effective in one. This was in a randomized, placebo-controlled, double-blind trial, and I think we can be sure that the subjects in this trial gave informed consent. So that's with the placebo effect kind of held in check. even under those stringent conditions, the drug was just that much better, kind of, you know, some people say better than nothing. Adalimumab, Humira, which you can see advertised on TV, was approved by the FDA in 2012 for the treatment of moderate to severe ulcerative colitis on the strength of 2 studies, one of which showed that 4.4% more subjects achieved sustained remission on that drug than on placebo. And just as I was putting the final touches on this talk 2 days ago, it was, I got, came across my email or something that a list has come out of drugs whose prices increased the most between December 31st, 2010 and today. Humira was number 1 on the list. So this is a drug, again, it's approved, it has many indications. It's not just approved for severe ulcerative colitis, but for that indication, the drug surpasses placebo by 4.4%. From December 31st, 2010 to today, the price of Humira rose 126.4%. Here's another one. In one trial, a high placebo response completely nullified the expected superiority of fluoxetine, that's Prozac in this case, over placebo as a PTSD treatment. So, you know, we've gone from 18% superiority to 10 to 15%, down to 8%, 4%, but now we're down to 0. This is a trial in which a high placebo response negated the expected superiority of Prozac over placebo as a PTSD treatment. The interesting thing about this study is it's designed for me. It was not a 50-50 study. In other words, the placebo effect was not well controlled as it is in the 50-50 study. It was it was a 2 to 1 study. So that subjects knew that they had an 80% chance of getting an active treatment. So the placebo effect, their expectations were raised by that. Right? The 50-50 message tends to kind of deflate people's expectations. And I've always thought that one of the reasons it's hard to recruit people into clinical trials in the first place is because they know a lot of people don't want to subject themselves to the possibility of receiving a placebo. And on the other hand, a certain number of people in clinical trials don't understand that they are exposed to the possibility of placebo. Somehow the informed consent message just doesn't get through. So in this trial that I'm on right now, it has an unusual 2 to 1 design such that subjects had and knew they had an 80% chance of getting an active treatment, quoting the study, leading to high expectancies of getting better, which can drown out the more modest contrast that exists between drug and placebo. There you go. So what if you're dealing with one of these ambiguous drugs with a modest contrast, if any, between drug and placebo, and you let the placebo effect do its work? That drug is going to have an awfully hard time. But if you repress the placebo effect, which informed consent does, that drug will have a better probability, I think, of success. And now were these nuances thought out when these factors were coupled in the legislation which to this day governs the FDA? No, not really. So here are some implications. And I'll draw a few implications from this and then open the floor up. But so I mentioned that when drugs like this were sweeping the market, critically minded medical people, people who are beginning to think in a kind of methodical way about the placebo effect, were concerned. And they realized that with hundreds of drugs entering the market each year, none of them required to show efficacy beforehand. the results really compromised clinical judgment and practice. So people like Henry Beecher of Harvard, who's really kind of one of the pioneers of placebo studies, wanted to see randomized clinical trials required so that drugs, his term, only a little better than placebo, could be smoked out. Only a little better than placebo. And what I'm suggesting is that through no one's design or intention, I think, what the clinical trial system today does is allow drugs that are only a little better than placebo to show efficacy. And one of the reasons they do that is that informed consent helps. Informed consent, which I do believe is a first principle of bioethics. But informed consent has, what should we say, like side effects? Even it has side effects. So if there are many questionable drugs on the market, and by that I mean drugs that are questionably superior to placebo on the market, we don't have to invoke a conspiracy on the part of big pharma to account for them. You know, I don't think I've been bashing big pharma today. I think the law of unintended consequences is enough. So that's why I said this is a story of unintended consequences. Who in the 1950s was intending, or who, even when Congress voted unanimously for this legislation, who was intending a system that would make it possible for a drug, 2% better than placebo to hit the market? Let me just point out one other thing about this phrase, this innocent phrase, adequate and well-controlled investigations. You can understand why Congress doesn't want to get too specific about how to run a clinical trial, right? And they were wise not to do that. But was something I haven't mentioned today, but that Kirsch certainly mentions and hits in his expose of SSRIs, the Emperor's New Drugs, meaning there's no drug there. It's naked. In order to, a drug has to show efficacy in 2 trials. No matter how many negative trials it has, so long as it shows efficacy in 2 trials, positive trials, it's okay. And believe it or not, the basis of that is just the plural. It's just the letter S on investigation. You know, I tell students at the university, sometimes words matter. That plural is the basis of it's pretty much the basis of the clinical trial system as the FDA runs it today. I think the FDA obeys the language, the language of the law. There it is. So say a drug that's 5% better than placebo is on the market. That means that on average, 20 patients will need to be treated with the drug in order for 1 patient to benefit from it as something other than a placebo. Try that again. So if a drug is like 5% better than placebo, that means, according to this NNT, number needed to treat calculation, standard calculation, that basically on average 20 patients would need to be treated with the drug in order for 1 to benefit from it as something other than a placebo. Do those 20 patients really understand the score? I don't think so. I doubt it. Even in this bioethical age. And if I'm right, then in order to clean deception out of clinical trials, informed consent is intended to clean deception out, right? Sweep out those stables. Clear the dung from the stables. If I'm right, that the 20 patients who take drug X without understanding that for them it's probably just a placebo, if I'm right about that, then in order to clean deception out of clinical trials, we've just shifted deception onto the general public. A couple of years ago, I was asked to write an editorial for the Journal of the Royal Society of Medicine about the use of placebos in medical practice, not in clinical trials, in the clinic, in practice. There's a lot of good evidence about on this. There are polls of doctors that have been done in many countries, including the US. And to me, they all tell a fairly similar story. The evidence suggests that the practice of using placebos is quite common, not that sugar pills are making a comeback. So sugar pills, so if we have the idea that something is either a drug or a placebo, it's either a sugar pill or not a sugar pill, right. But sugar pills aren't the problem. And doctors do not tend to use sugar pills. Surveys, one after another, report or show that doctors do prescribe unnecessary antibiotics and sub-threshold doses of medication and nutritional supplements and stuff like that with some frequency. Okay, that's quite common. But if you prescribe an approved drug, FDA-approved drug, whose effect is placebo in most cases, should that be counted as prescribing a drug or as prescribing a placebo? I mean, arguably, it could be the second, right? I mean, if 10 patients have to take a drug in order for one to benefit from it, then, okay. So the superior to placebo standard, some critics call the better than nothing standard. You know, all that a drug has to be is better than nothing. Some call that minimalist. This minimalist standard or criterion of efficacy has been in place since 1962, when informed consent was a new concept and an untried practice. Well, this minimalist criterion of efficacy allows for the approval of drugs that are only a little bit superior to placebo. And some would say that criterion is too weak. When the new head of the FDA, Robert Califf, was approved, some medical observers predicted, quote, he may try to raise the bar for drugs that have shaky support from clinical trials. I quoted that from MedPage today. This is February 26th, a few weeks ago. So maybe I'm onto something. So the new commissioner of the FDA may try to raise the bar for drugs that have shaky support from clinical trials. Okay. Finish up. Just mention my favorite placebo researcher, and a very ethical-minded guy too, Fabrizio Benedetti, commented on the sharply rising placebo effect in American trials of certain pain-killing drugs, such that the drugs are now only less than 10% superior to placebo. What he said was, quote, I don't think that controlling the placebo response will increase the number of successful trials. What drug companies have to do is find more effective drugs. Maybe that is the right conclusion. I mean, maybe maybe the phenomenon that I've been identifying is just the kind of hitting the wall phenomenon. And pharmaceutical companies who sponsor and manage, who farm out the management of clinical trials, regard the placebo effect as their as a massive nuisance and their great nemesis. The idea is that it's the noise, right, that drowns out the drug signal. So if you suppress the noise, you can bring out the signal. To some extent that's true, although as we can see, the returns are approaching zero for many drugs. And maybe the simple conclusion to draw is Benedetti's conclusion, that we just have to find more effective drugs. Okay, so that's the controversial conclusion that I promised to deliver. Yes?
Thank you for the smart presentation. Can you, in your last statement, you said that what company should come up with effective medication?
You know.
But yet in the discussion, you use the word efficacy. Why didn't you, do we need to separate clinical significance from statistical significance?
Yeah. The word significant is thrown around a lot, and I just taught a course on the placebo effect on campus, and I really hit that point, that there's a difference between statistical and clinical significance. I mean, if a drug is 4% superior to placebo, that's a statistical matter, right? And it might be clinically indistinguishable. And so if I say that, well, 20 patients would have to be treated for one to benefit, that's just the kind of statistical artifact. Kirsch's argument, very simply about SSRIs, is that, yes, there are trials in which they show statistical superiority to placebo, but clinically the difference is probably meaningless. I think they're two different things. Clinical and statistical significance are two different things covered by one word. Yeah. Oh.
Thanks.
It seems to me, and I'm an old-time doc, I grant, and I'm one of those folks that has used placebos knowingly. But there are a great many patients with a great many pretty debilitating conditions. For many of them, especially with the psychological problems and the lack of availability of quality psychotherapeutic work, if you give them a drug like Paxil and you say, now this doesn't work for everybody, but let's give this a try, it works for a lot of people. Now, is it placebo? A lot of it is, sure, we know that. But there are some physiological effects of the drug, and the patient, people do better. It seems to me the problem is, when you're looking at this from a research study, if you will, but I think the problem is more that doctors need to be clear that the effect is not going to be all physiologic.
Yeah. Sure.
And I think sort of on a related note, you know, that I feel that you approach this from a perspective of we're not demonstrating that these things have a significantly greater effect than placebo, and that's bad. But what is the cumulative effect? I mean, we can have a whole separate discussion about the ethics of prescribing placebos for clinical effect, but in the absence of a better treatment for depression than SSRIs, if 50% of people get better on an SSRI, but only 5% of that's due to the effect of the SSRI, I guess we, you know, again, a separate conversation about whether or not this is preventing us from developing better drugs because companies are focused on marketing their current medicines. But it seems like if we can, in some ways, it's kind of an advantageous that we have these drugs with a incremental better effect than placebo available, because we don't have anything better than those things, and the placebo effect can be pretty powerful.
There's no doubt about the placebo effect being powerful, though it's not necessarily reliable. That's a problem. And I've got to say that Irving Kirsch, the guy who wrote the expose on SSRIs, the inversion of drugs, totally disagrees that there are no other or better treatments available. Yeah. Yes.
One more, excuse me, question to ask you. Almost every condition you mentioned is a syndrome.
Pardon me?
Every condition you mentioned is a syndrome or a collection of symptoms that we're trying to find a remedy for.
Yeah.
Do the principles that you raised, and I agree with you, by the way, and you are too kind to pharma by my standards, do the principles that you raised apply to conditions like heart failure, atrial fibrillation, diabetes, hypertension, where you have an instrument to measure things?
Where you have an instrument?
To gauge progress or lack of.
Yeah. Placebos are better at treating symptoms, right? I mean, they promote symptomatic improvement. Beyond that, I wouldn't go very far with them. Hypertension, to some degree, is responsive to placebo, isn't it?
Everything is.
Well, not everything, but
Well, actually, if you look at the study, there are people who argue that if you gave someone a placebo, it's no longer a placebo. But in every study, I mean, the earliest studies that have been done, there has been a placebo effect. Everything is beneficial, depending on the outcome. Death, everyone is going to die.
yeah, there are especially placebo-dependent conditions. I mean, IBS, which I've mentioned, is obviously one. I'm sure you see that in clinical practice. Depression is obviously one, right?
I would argue that actually I totally agree with him. Everything has a placebo effect, but I would also clarify that psychological is physiological. In other words, we're trying to, I think part of the problem is we are mixing up, we act as though treating heart failure has, I'm sorry, I'm not being clear here. I think placebos are good. I think we use them all the time. Numbers needed to treat in almost all the cardiac studies. If you get a number needed to treat of 20, we all think we're doing well. So I'm not really dissuaded in using antidepressants based on, and I understand these arguments. I think really what it says is what we do with drugs is a pretty minimal thing. It's only it's a small part of what we do. And maybe we're not having any benefit to anybody, but it's hard to believe that in day-to-day practice, that we're not having, benefit. So it's not just IBS and depression. It is, the placebo effect runs the gamut. And then you can say, well, that's just psychological, but psychological to me is physiologic. And so if you use the placebo effect in a good way, and, I don't know, you mentioned that there are better drugs, that the author you were describing. I can't imagine that if there are better drugs that they're not out there getting approval. So can you give us an example
I think
of
what
one
you
of
said
those?
that might have been the last quote I gave. He said, what we need is better drugs.
Right, but you also, I thought, said that he said there are better drugs out there.
No. What drug companies have to do is find more effective drugs. I think everybody knows that's not easy. Maybe you do get the sense of diminishing returns, right? Yeah.
The book that he's referring to, I think, is the one that recommends alternative treatments like exercise, not drugs.
Well, that's the Kirsch book. Yeah, it says that, right, exercise is it also has fewer of the adverse effects of SSRIs and so on. Yeah. One of many possible treatments. Yes?
This is really fascinating to me, and I think, ethically what to do with this in clinical practice is something I think all of us struggle with. And, the clinical environment, I would argue, is somewhat different than the clinical trial environment. In a clinical trial, you do really want to find truth. In the clinical environment, you want to make the patient better. But we also have obligations to be honest with our patient and to avoid things that are, potentially can cause them real harm. And, so where do you, and I've heard people come down on both sides, and I think we're swinging towards, in clinical practice, being more honest and upfront with patients. And does that mean we're really sort of undermining our ability to use placebo effectively? And, if the drug is the only hammer you've got, you want it to be as effective as possible. At the same time, if overstating the effectiveness of our hammer means that we don't expand our toolbox, which I think we tend to limit ourselves a lot, and we don't push as hard on people to make those lifestyle changes or to exercise when they're depressed, because it's easier to give them a drug of marginal efficacy in clinical practice, and that's the kind of pathway of least resistance. This is really ethically muddy and hard in clinical practice to figure out what we should do. And I think you can make compelling arguments on both sides about, do you knowingly amp up that placebo effect when you're counseling patients? Do you shy away from it because you really want to push them towards other therapies? I think it's a hard call.
Yes.
I guess in response to you, Rob, this talk, I think, just reinforces the idea that we need to be humble in clinical practice. And so for me, available therapies shouldn't be destiny, right? We label people as non-compliant, quote unquote, all the time. And I think that's bogus. I hate that concept. we're actually criticizing our patients for not taking medicines that are marginally helpful at best. And that's terrible. So I don't know. I tend to come down on the side of radical openness to the degree possible. And if that compromises my ability to use placebo, then so be it. I mean, I think a rich understanding of autonomy kind of calls for that.
Yes.
So, I have a little bit of experience doing clinical studies, and in the last 15 years, I would guess that there have been maybe 2 or 3 medications that have targeted new pathways. The best-selling medications, if you look at a medication by the name of Flexapro, it's nothing more than chemical manipulation of the parent compound. If you look at some of the other SSRIs, it's the same way. One of the most antiarrhythmics, best-selling, has been chemically manipulated. So I always share with my colleagues that I have call it healthy or unhealthy cynicism. Because when I look at studies and I look at the statistics, the numbers have been subjected to waterboarding and torture. And if you torture them enough, they will confess.
How about just one final point and we'll wrap it up? Okay. There were a couple of questions from the floor or kind of agonized reflections. Can I use a placebo in practice while telling the patient that this is a placebo, which certainly seems pretty bizarre. I just want to mention that, believe it or not, there was a study done in 2010 with Irving Kirsch, the guy I mentioned, was one of the authors of it, as a matter of fact. It was widely cited, in which, yes, people were treated with placebo and told that it was a placebo for IBS. I mean, they really were explicitly told. There was no monkey business there. They were told, and whatever. I'm going to leave out a lot of nuances, but the study was positive. So the take-home message of the study was that, at least in principle or in theory or something, it might be possible to use a placebo while telling the person receiving it that that's what it is. I'm not a great believer in that study. I don't, but there's a real bandwagon behind that study. Most people do accept it. It's got very good press. Okay, I think thank you.